Mycobacterium tuberculosis, Mycobacterium or aerobic slender bacilli, non-motile, non-capsulated, non-sporing. They are difficult to stain, but once stained, resist decolorization with a dilute mineral acids and therefore called acid fast bacilli or AFB. The growth is generally slow. The genus includes obligate parasite or opportunistic pathogen and saprophytic Mycobacterium. Four closely related species are responsible for mammalian tuberculosis, Mycobacterium tuberculosis, human tuberculosis, Mycobacterium bovis, bovine tuberculosis, Mycobacterium microti, old tubercle bacilli, and Mycobacterium africanum. Mycobacterium tuberculosis, Mycobacterium bovis, or typical tubercle bacilli and causes human lesions such as pulmonary tuberculosis. Classification: Mycobacteria causes human diseases may be classified as cultivable, typical tubercle bacilli, mammalian. The human type Mycobacterium tuberculosis, bovine type Mycobacterium bovis, world type microti, African type Mycobacterium africanum, atypical Mycobacterium photochromogens, scotochromogens, non-photochromogens, and rapid grower. Mycobacterium causing skin ulcers, Mycobacterium ulcerans, Mycobacterium balni, saprophytic Mycobacteria, Mycobacterium smegmatis, Mycobacterium butyricum, Mycobacterium stercoris, Mycobacterium fairly non-cultivable, Mycobacterium leprae. Mycobacterium tuberculosis morphology. Mycobacterium tuberculosis is a slender, straight or slightly curved bacilli with rounded end occurring singly in pairs or in small clumps. It measures 1 to 4 micrometer into 0.2 to 0.8 micrometer, average 3 micrometer into 0.3 micrometer in size. These bacilli are acid fast, non-sporing, non-capsulated, and non-motile. Ziehl-Neelsen staining is useful to study the morphology of this organism. With this stain, the tubercle bacilli are seen bright red, acid fast, while the tissue cells and other organisms are stained blue. The tubercle bacilli may also stained with fluorescent dyes, auramine O, rhodamine, and appears yellow luminous bacilli under the fluorescent microscope. Beaded or barred form are frequently seen in Mycobacterium tuberculosis. They are gram positive but are difficult to stain with gram stain due to the failure of dye to penetrate the cell wall. Mycobacterium bovis appears straighter, stouter, shorter, and staining is uniform. Culture: Mycobacterium tuberculosis is obligate aerob, whereas Mycobacterium bovis is a microaerophilic on primary isolations because aerobic on subculture. The bacilli grow slowly, generation time 14 to 15 hours, and the colonies appears only in about 2 weeks, and sometimes it takes up 6 to 8 weeks. The optimum temperature for growth is 37 degrees centigrade, range 30 to 40 degrees centigrade. The optimum pH is 6.4 to 7.0. The tubercle bacilli can grow on wide range of enriched medium, but Lowenson Jensen media is most commonly used. The LJ medium consists of a beaten egg, aspergine, mineral salts, malachite green, and glycerol or sodium pyruvate. It is solidified by heating. Inspiration. It is one of the medium which are solid without incorporation of agar. In this medium, egg acts as solidifying agent. The malachite green inhibits the growth of organisms other than Mycobacterium and provides a color of medium. The addition of glycerol improves the growth of a human type of Mycobacterium tuberculosis, while it is without any effects of even inhibitory or to Mycobacterium bovis. The colonies of Mycobacterium tuberculosis are dry, rough, buff color, raised with a wrinkled surface. They are tenacious and not easily emulsified. The colonies of Mycobacterium bovis are flat, smooth, moist, and white, breaking up easily when touched. Mycobacterium tuberculosis has a luxuriant growth, eugonic growth in culture as compared with to sparsely growth, dysgonic growth in Mycobacterium bovis. The virulent strain tends to grow as serpentine cord in the liquid medium, while avirulent strain grows in a more dispersed fashion. Differentiating feature of Mycobacterium tuberculosis, Mycobacterium bovis. Morphology: Mycobacterium tuberculosis long, slender, and usually curved. Mycobacterium bovis short, stout, straight. Staining: Mycobacterium tuberculosis barred or beaded appearance. Mycobacterium bovis uniform staining. Growth of LJ medium. Mycobacterium tuberculosis eugonic growth. Mycobacterium bovis dysgonic growth. Presence of glycerol in medium. Mycobacterium tuberculosis enhance the growth. Mycobacterium Mycobacterium bovis inhibits the growth. Colony characteristics: Mycobacterium tuberculosis: dry, rough, tough, raised and wrinkled, creamy, white or buffed colored, difficult to emulsify. My colony characteristics of Mycobacterium bovis: moist, smooth, flat, white and friable. Biochemical reactions: Mycobacterium tuberculosis, niacin test positive and nitrate reduction test positive. Mycobacterium bovis, niacin test negative and nitrate reduction test negative. Animal pathogenic test in guinea pig positive, progressive and fatal disease. In Mycobacterium tuberculosis in guinea pig, positive disease similar to that of Mycobacterium tuberculosis. In rabbit, it's negative or mild lesions. Mycobacterium bovis in rabbit, generalized lesions. In the cod factor, which itself is not responsible for valence, it is also present in some non-pathogenic species of mycobacteria. The cod factor consists of two mycolic acid linked to the molecules of tricholose. The various culture medium used for mycobacterial lesion includes Lowenstein Jensen media, Petra Nani, Dorset egg medium. All the three are egg based, and Middlebrook 7H10, Middlebrook 7H11 agar based medium. Dubose medium and Middlebrook 7H9 are two commonly used liquid media. Resistance: Mycobacteria are killed at 60 degrees centigrade in 15 to 20 minutes. They are sensitive to ultraviolet rays and sunlight. The bacilli are destroyed by 80% of alcohol in 2 to 10 minutes. They may remain viable in droplet nuclei for 8 to 10 days. Biochemical reaction: the niacin test and nitrate test are positive with Mycobacterium tuberculosis disease. The pulmonary tuberculosis, extrapulmonary tuberculosis. Immunity and hypersensitivity. Two immunological responses developed simultaneously in a naturally infected host. One is anti-tubercular immunity and other being tubercular hypersensitivity. Both responses are mediated by T lymphocyte. Humoral immunity appears to be of no relevance in tuberculosis. Coach phenomenon: when a healthy guinea pig is inoculated subcutaneously with virulent tubercle bacilli, the puncture site heals quickly and there is no immediate visible reactions. After 10 to 14 days, a nodule appears at the site of injections, which ulcerate and ulcer persists till the animal dies of progressive tuberculosis. A regional lymph node or enlarged and caseous. If on the other hand virulent tubercle bacilli are injected in a guinea pig which has received a prior injection of tubercle bacilli 4 to 6 weeks earlier, and induration lesions appears at the site of infection in a day or two, which undergoes necrosis in another day or so to form a shallow ulcer. This ulcer heals rapidly without involvement of regional lymph node or tissue. This is known as a Koch phenomena. The Koch phenomena is a combination of hypersensitivity and immunity. Tuberculin skin test. Montex, it is a delayed or type 4 hypersensitivity reactions. 0.1 ml of purified protein derivatives containing 5 international units is injected intradermally into a flexor aspect of a forearm. In India, 1 tubercle unit of PPD or T23 is recommended and not PPDS. The site of injection is examined after 48 to 72 hours. In a positive reactions, there is an induration local edema of 10 mm diameter or more surrounded by the erythema at the site of inoculations. The positive test only confirms past infections with the tuberculin bacilli, but it does not indicate presence of active stage of disease. The test is helpful in children under 5 years of for indication of active infections. The test become positive 4 to 6 weeks after infection or BCG vaccination. Laboratory diagnosis: the bacteriological diagnosis can be established by microscopy, culture examination or by animal inoculation. Specimen: the specimen collection depends on the site of involvement. Pulmonary tuberculosis sputum 3 consecutive days morning specimen. Laryngeal swab, bronchial washing, gastric washing in children. Meningitis, CSF, rectal, renal urine 3 renal tuberculosis urine 3 consecutive days morning sample. Bone and joint tuberculosis, aspirate fluid, tissue biopsy of tissue, direct microscopy, smear is made from the specimen and stained with Zeal Nielsen technique. The grading of smear is done according to the number of bacilli in grading of Zeal Nielsen smear. 0/300 fills A, B not seen. 1 to 2 per 300 fields doubtful, repeat this smear. 1 to 9, 1 by per 100 field 1 plus 1 to 9 per 10 field 2 plus 1 to 9 per field 3 plus 10 or more per field 4 plus the microscopy is also performed of the smear, which is prepared after concentration of the specimen. If a large number of smear are to be examined, the fluorescent microscopy is more convenient. The demonstration of AAB by microscopy provides only presumptive evidence of tubercle infection, as a saprophytic Mycobacterium may present a similar appearance. Concentration of specimen. The concentration of specimen is done to achieve homogenization of specimen. Decontamination, that is to kill other bacteria present in the specimen. Concentration, that is to concentrate the bacilli in a small volume without inactivation. Such concentrate is used for culture and animal inoculation test besides smear preparation. Several concentration methods include Petrov method: dilute acid 5% oxalic acid, 3% hydrochloric acid, and 6% sulfuric acid, N-acetyl L-cysteine with sodium hydroxy, and pancreatin. Culture. The culture is very sensitive method for detection of tubercle bacilli. It may detect as few as 10 to 100 bacilli per mammal. The concentrated material is inoculated on 2 bottles of Lowenson Jensen medium. The culture medium or incubated at 37 degrees centigrade in a dark and in light. The culture are examined up to 8 weeks before reporting as negative. In a positive culture, the characteristic colony appears on the medium. The smear is prepared from isolated colony and stained with Ziehl-Neelsen technique. When acid was bacilli is slow growing, non-pigmented, and niacin positive, it is regarded as Mycobacterium tuberculosis. In radiometric methods such as BACTEC, the growth may be detected in about a week by using carbon-14 labeled substances. The radioactive labeled carbon dioxide 14 is measured in terms of growth index. A growth index of less or equal to 10 is considered as positive. This significant method has been discontinued due to radioactivity. The mycobacterial growth indicator tube is a rapid method for detection of Mycobacterium tuberculosis. It is not a radiometric fluorescent based method. BACTEC alert 3D system is not a non-radiometric rapid and 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 fully automated method for culture. It is based on color changes in sensor present in the liquid medium vial. Animal inoculation. The specimen is inoculated intramuscularly into the thigh of 2 tubercle negative healthy guinea pig. The caseous lesion develops at the site of inoculation. The tubercle may be seen in the spleen, lungs, liver, or peritoneum. There are enlarged caseous inguinal lymph node. The identity of the bacteria is confirmed by demonstration of acid fast bacilli from the lesion. Mycobacterium tuberculosis is highly pathogenic to guinea pig and virtually not pathogenic for rabbits, while Mycobacterium bovis is highly pathogenic for both rabbit and guinea pig. Guinea pig inoculation is rarely used nowadays for laboratory diagnosis. Identification of Mycobacterium. Growth on LJ medium. Slow growth, rapid growth within 7 days. Growth on McConkey aryl sulfate test. Slow growth niacin test. Niacin test negative and positive. Negative type of growth and positive Mycobacterium tuberculosis. Rapid growth at McConkey aryl sulfate test. Positive M fortune complex, negative tellurium reduction, positive Mycobacterium semimatis, and negative Mycobacterium feli. A type of growth: scanty, smooth, flat colonies, Mycobacterium and pigment protections. Scanty, smooth, flat colonies in rapid pathogenicity, negative for BCG and positive for Mycobacterium bovis. Pigment protection in light, in dark, no pigment. In light, group 1; in dark, group 2, no pigment. Group 3; in light, group 1 called photochromogen, group 2 in dark called scotochromogen, and group 3 in no pigment called non-photochromogen. Serology includes detection of antimicrobial antibody in patient serum. The diagnostic utility of this antibody is equivocal. WHO has recommended that these tests should not be used for diagnosis of active tuberculosis. Molecular methods: polymerase chain reaction DNA probe has been used to identify mycobacterial species isolated on the solid culture medium or from the broth culture. Ligase chain reaction LCR, transcription mediated amplification. Chromatographic method: mycobacterial lipids are analyzed by this method. Gas liquid chromatography, high performance liquid chromatography, and HPLC and thin layer chromatography has been used to identify mycobacterium. Sensitivity testing: resistance ratio method, absolute concentration method, proportion method, mycobacterial growth indicator tube, Bactec alert 3D system, chemiluminescence, and epsilometer test. Treatment: a combination of drugs is used for treatment of tuberculosis. If a patient is treated with only one anti-tubercular drug, initially they basically die in large number, but soon resistant mutation emerges and multiply unchecked. A serious consequence of unchecked drug resistance has been the emergence of multi-drug resistance tuberculosis. The term multi-drug resistance refers to the resistance of rifampicin and isoniazid with or without resistance to one or more other drugs. Prophylaxis: the protection from tuberculosis may be done by public health measure and BCG vaccination. General measures such as nutrition and health educations are also important. BCG vaccine: the Bacillus calmette-guéri vaccine is available in liquid form and freeze-dried lyophilized form. The freeze-dried form is commonly used. The recommendation vaccine is given intradermally in a dose of 0.1 ml. BCG vaccine should be given soon after birth, failing which it may be administered at any time during the first year of life. A small nodule developed at the site of vaccination 2 to 3 weeks after injection. It increases slowly in size and attains a diameter of 4 to 8 millimeters after about 5 weeks. It then subsides or breaks into shallow ulcer which heals spontaneously, leaving a 4 to 8 millimeter diameter, a permanent round scar. Such individual becomes a tuberculin positive after 4 to 6 weeks. A number of BCG vaccine trials were undertaken to find out the protective efficiency of vaccine. The results varied from 0 to 80%. The immunity has been reported to last for about 10 years. The general opinion at present is that GBCG does protects from tuberculosis. Even if disease occurs, it runs a milder course in vaccinated children. It is also believed to prevent serious forms of tuberculosis such as meningeal, skeletal, and multiform of disease. Reverse National Tuberculosis Control Program (RNTCP). Under RNTCP, any patients with a cough for 2 weeks or more is included for the diagnosis of pulmonary tuberculosis. The diagnosis is mainly based on good quality microscopy. 2 sputum samples are collected from the patient's only early morning specimen, and other is collected on spot when patient visits the chest clinic. Cough for less than 2 weeks. Two sputum specimen, one morning and other spot. The smear from both specimens stained with Ziehl-Neelsen staining. One or both positive for AFB, but both negative. In one or both positive for AFB, sputum positive pulmonary tuberculosis, and DOTS started. Both negative, antibiotic 10 to 14 days. Cough persist. Repeat 2 sample smear examination and Ziehl-Neelsen staining. One or both positive for AFB, both negative. Sputum positive pulmonary tuberculosis and dots distorted. Chest X-ray. And finding suggestive of tuberculosis, finding negative for tuberculosis. Finding suggestive of tuberculosis, sputum negative pulmonary tuberculosis and dots started. Finding negative for tuberculosis not present.